These are the three visions of need the final result. And not treatment is LGBT treatment. So what you see here is the first step, is the assessment in terms of diagnosis, because we are collecting all the parameters, as you can see in the pictures. For example, on this implant, we have 5, 4, 7 millimeters in the buccal aspects, but we don't have any bone loss. So we have a mucositis, a severe mucositis with a severe and profuse bleeding on probing, and a lot of plaque, supragingival plaque. We have mobility, for example, in this tooth, 1.2. We have very severe pocket defect here in the mesial buccal sides of 1.1 and with a bone loss as you saw in the X-ray. And then we continue with the probing in every single side, and we test the bleeding on probing, the probing pocket defect, the recession, another implant here, and 2.3, another mucositis size, because bleeding on probing but not bone loss. And we also check the mobility, the furcation with the neighbor's probe, and of course the suppuration size, and also the condition of the gum, of the soft tissues in terms of recessions and keratinized quantity of keratinized tissue. So you can see here and here the use of the neighbor's probe, the angulated probe, to check the furcation lesion, like in this second molar, where we have 6 probing pocket defect and also furcation lesion. And we do the same in the lower teeth, following the same steps. And during these kind of probing, we can also have an idea of the quality of the soft tissue to decide if we can use the periflow nozzles in that side. So, for example, I showed you this lower incisor because I used the periflow nozzles there in this defect, because it's possible. We don't have separation, we have just bleeding on probing, we have good keratinized tissues, we don't have an periodontal abscess or a fistula. So of course in this situation we will remove the biofilm from the root surface with the periflow nozzle, because we want to have something more on the root surface to improve the possibility to eliminate the biofilm compared to the only use of the PS instruments. This is the result of the assessment of the probing, and we have in the upper jaw bleeding on probing in all the sides, so 100% with 100% of level of plaque, and a lot of sides with 5, 6, 7 millimeters. But not a very severe condition. We see more severe conditions, but the infection is very high because the patient is not compliant at all. And also in the lower jaw we have, as you see, a lot of red and blue point. That means bleeding on probing and plaque. And the numbers of the probing pocket defect in red, that means more than 6 millimeters. So this is the risk assessment, high, so knock some bone. This is the diagnosis, putting the data in the table. So we have stage 4 periodontitis for 3 reasons. and we have a grade C periodontitis for at least two reasons. The percentage of bone loss, and also because he is a heavy smoker, more than 10 cigarettes per day. So the diagnosis is a generalized periodontitis, stage 4, grade C. And in the same session, we started with the therapy. Sandro improved pain of the agent and results we sent of plaque, more agent plaque. How we started motivating Alessandro. We decided to start with a simple manual toothbrush, because for him was the first time with a toothbrush, probably. No, it's the first time he received a very high quality motivation and education. So we showed him how to clean the sulcus and the marginal gum with an intracircular technique with a soft toothbrush with soft bristles. And then we start explaining him how to use the interdental brushes, different colors, different measures, size, especially where he has the implants, because we need to clean the transmucosal part going into the sulcus, not only with the interdental brush but also with the floss, because the floss, as you can see here, can go directly into the sulcus and can hug the crown and the abutment of the implants, obtaining and getting a very high quality of cleaning. So it's very important to explain the two things. And here again, the literature. We published also a paper where we demonstrate that the sonic toothbrush combined with the GBT sessions is superior to finally, so we started from powders to the plus powder, moving millimeters distance from teeth and icons in the same place. So you need to move too slowly to be effective and not to create any kind of damage on the soft tissues. Of course, the patient has bleeding on treatment, because the patient has a periodontitis with a high level of inflammation. So you saw during the assessment and diagnosis probing. So treatment, especially here in the subgingival area, when you deliver the powder in the subgingival area, in the sulcus, but especially into the area where we have pockets. And you see that we don't care about the calculus at the beginning, but we clean the calculus. We try to remove the biofilm from the calculus, the supragingival calculus, and just at the end, only at the end of this part, we will remove the supragingival calculus and the subgingival calculus with the PS tip. But during this step, you start to reduce the infection and the bacterial load in the mouth, and you will be able to see very well where the calculus are positioned and how you need to remove the calculus. Use the PS tip, or sometimes if you need some angulated tip, you can use the PSR or the PSL to have an advantage in terms of position to get the sides. And of course, you can deliver the plus powder in the transmucosal tunnel and on the crown of the implant. So you can use the erythritol powder wherever, on the ceramic, composite. And here another pH cap. In terms of the age approach, that the sixth step, the periflow nozzle in the periodontitis patients in this kind of sites, as you can see, 7 millimeters in this pocket, but also in the periimplantitis patients and in the mucositis. And in this case, we have mucositis and periodontitis. So you can see in the video how we use the periflow nozzles. Before we need to check the pocket with the probe, and then we need to put the periflow nozzles in the sides, and the movement will be like up and down, but you can also move a little bit medial and distal if you have a wide pocket. And when you activate the pedal and the power, you need to stay in 50, 60, 70% of power with 80, 100% of water. And what I suggest is to press with your finger the mucogingival line to avoid the risk of emphysema. But in these cases where we have a very good soft tissues, not in terms of inflammation, but in terms of thickness, there are no problem, no risk. And you can see here in this implant how in those mucositis implants, how the nozzle is comfortable and is useful to clean the crown, to clean the transmucosal tunnel, to clean the abutment area. And also in these severe and deep pockets in this 1.1 incisure. And I want to tell you that all the treatment that you are watching is without any anesthesia injection. So we can treat in the 90% of the cases the patient without anesthesia. So it seems aggressive, but it's not, totally not. So without injection, even if we have a very high inflammation, because the treatment with periflow and PAS tip is very, very delicate, if you are delicate in moving the instruments into the pocket. So let's go to the piezo instrumentation, supra and subgingivally. Of course, supragingivally, it's easy to see if you are able to remove completely the calculus, because you can see the calculus. Of course, you need to work with your magnification, so with your loops and with your light, and you need some time to deshydrate the teeth with the air syringe to see if there are any other calculus. But subgingivally, we don't have this visual control inspection. We need to feel with the probe or the explorer if you need to work more, but the only way to see if our treatment is effective is to control, is to reevaluate the patients. And if we have a residual pocket, we need to retreat these pockets and continue with the non-surgical therapy up to 3-6 months, repeating treatment and remotivating the patients. And then if after 6 months we are not able to get the results, so the pocket closure, we need surgery. And so we need another step of active therapy, that is the periodontal surgery. And when we stabilize the patient, so we close all the pocket, we can put the patients in maintenance, in the supportive therapy. In this part of the video, you can see also how we use the PI tip, so the peak tip, in the mucositis treatment. So a combination between periflow nozzles and PI tip to have the cavitation and the vibration, subgingival vibration, to remove eventually residual cement residual of cement if we have cemented crown, or calculus if there are any calculus in the first 4 or 5 millimeters of the transmucosal tunnel. Usually it's big, the tip, the PI tip, as you can see here, it's a big diameter, but if you have a very inflamed transmucosal tunnel, there are no problem in introducing the PI tip. So in this situation, it's very useful. And here you have the again the evidence. This is the B-centric study that we did with Professor Trombelli at the University of Ferrara, where we treated 2 groups of patients, one group with the complete protocol of GBT, including the perioflow nozzles, and the other group with GBT but without the perioflow nozzles during the active therapy of periodontitis, severe periodontitis. And we obtained very, very good results because we closed most of the our loops and the air syringe of tissues and look into the air syringe to dehydrate and to move the soft tissues and look into the moderate pocket. And if we see, if we identify some calculus, some mineralization, residual mineralization, we redo the piezo instrumentation, and where we remove the supragingival calculus, normally we refine also with the erythritol powder to be sure to remove all the biofilm that can remain under the calculus, the supragingival calculus. And okay, so we arrived to the last step, 8th step, to schedule the recall appointment following the periodontal risk assessment, low, medium, or high risk. But in this specific case, the periodontal chart again, during the there are some no results and being so also after 6 weeks. A high risk for 2 reasons, because he is a heavy smoker and is not able at the moment to reduce the number of cigarettes per day, so we have this risk. And also we have a lot of residual pockets exceeding 5 and will do after advantage also in terms of balance, in terms of occlusion, and replace the crowded